and 25. This year, we started with presentations from our young investigators who presented best papers in last year's Haracon. Then we had Dr. Ernest Choi, Professor Gerd Burmester, and now today we have Dr. Natasha Jordan from Ireland. So I would like to welcome all of you to this meeting, and I would acknowledge my team. Our president, Dr. Chandrasekhara, could not be present here today because he is busy in some other meeting, important one, because you know that he is busy with the IRACON organization and preparations. And then in the IRA eConnect team, I have Dr. Arghya Chattopadhyay, Dr. Damodaram, and Dr. Mohit Goel. And we've been working together to deliver these academic sessions on the behalf of IRA for you. So I would like to introduce Dr. Arghya, the moderator for this meeting today. As you all know that he is a young, dynamic, and very handsome rheumatologist from Kolkata, and the first time executive committee member of the Indian Rheumatology Association. And I think we are really lucky to have his talent, his organizational skills to deliver this academic sessions and also other things. So Arghya, over to you. Thank you.
Thank you, sir, for choosing this such an interesting topic for IRA eConnect. And today we have as a chair Dr. Sharat Chandra Mouli, sir. He is a senior consultant rheumatologist at Skins, Hyderabad. So, sir will run rest of the session as a chair of the IRA eConnect today's session on therapeutics on SLE. Over to Mouli, sir.
Thank you, Dr. Arghya and Dr. Vinod. Good evening, everyone. It's a pleasure to welcome you to this insightful session on therapeutics for SLE, CAR T-cell, and beyond. As we know, SLE remains a challenging autoimmune condition to treat, with emerging therapies offering new hope. Today, we will be delving into the exciting potential of CAR T-cell therapy and other advanced treatments in managing SLE, paving the way for improved patient outcomes. It is my great honor to introduce Dr. Natasha Jordan, our esteemed speaker tonight. Dr. Natasha Jordan, she is working as a consultant rheumatologist at St. James Hospital and Children's Hospital Ireland, Dublin. She is a clinical senior lecturer at Trinity College, Dublin, Ireland. Her research interests are phase 2 and phase 3 lupus clinical trials, juvenile SLE, metabolism and immunity in SLE, and maternal health in rheumatology. Tonight, Dr. Jordan will explore the cutting-edge developments in CAR T-cell therapy and beyond, providing us with an in-depth look at how these new approaches are reshaping the therapeutic landscape for SLE. Without further ado, please join me in welcoming Dr. Natasha Jordan. Dr. Jordan, we are looking forward to hearing your insights. The floor is yours.
Thank you very much for that kind welcome, and for Vinod and colleagues for inviting me again to speak with you. So this evening, I'm going to talk about therapeutics for SLE, including CAR T-cell therapy. Firstly, I'm going to talk about why we still need advances and new therapeutics for SLE. Then I'm going to talk about the latest biologic therapies that are emerging for the treatment of lupus. And then finally, I will build up to the exciting new treatment of CAR T-cell therapy. So SLE, where are we with treatment in almost at the end of 2024? So we all know as rheumatologists that this is one of the most difficult diseases that we have to treat in our clinical practice. Lupus is a relapsing, remitting disease. And the problem with the remitting part of the disease and the flares of disease is that each flare can cause organ damage accrual. And this is what leads to morbidity and mortality for our patients over time. Our lupus patients, even though they're generally a young cohort of patients, have a higher morbidity and mortality as compared to the general population of the same age. And even though therapeutic advances in lupus have improved dramatically over the last 50 or more years, we still have a long way to go. If you look back to the 1950s, things were really terrible, with a very poor 5-year survival of about 50%, which was very worrying and depressing. Now improvement has gone over 90% for 5-year survival. But we still have many, many challenges that I'm sure you share with me. Early diagnosis remains a challenge. We have a paucity or a lack of sensitive biomarkers. We still rely too much on corticosteroids. And our patients, as I said, even though young, can get accelerated atherosclerosis at a much earlier age than would be expected for young women. We also have many challenges outside of clinical practice in research. Our patient populations are very heterogeneous, so it is difficult to do trials. Also, there's a lot of debate about the best outcome measures and scoring systems for our lupus clinical trials. So the unmet needs in lupus that need us to look at therapeutics for this disease in 2024 are difficult to control disease. So when we think of that, we often think of obviously lupus nephritis, but also moderate and severe extrarenal disease. We have an unmet need of damage prevention. If we reduce activity and flares, we will reduce damage accrual. And then sometimes what lacks and lags behind is actually us acknowledging quality of life as an outcome for the patients themselves. They may have different goals than what we have in mind for how their health is improving or not. I just want to linger a bit on corticosteroids because one of the main reasons we need new therapeutics and biologics is to try and move away from corticosteroids and the damage they cause in lupus. So I don't need to tell you that steroids increase all the traditional cardiovascular risk factors like dyslipidemia, hypertension, BMI, and diabetes. But there's some really very worrying data that after 15 years of a lupus diagnosis, the majority of organ damage can be attributed to steroids rather than the lupus itself. And while we know that higher doses of steroids are risky, we don't really know if there's any such thing as a safe dose of steroids. And again, cumulative steroids have a significant association with morbidities like cataracts and osteoporosis. So it's the current dose of steroid and the cumulative dose that we're worried about with cardiovascular events. And again, all of this could be minimized if we had better therapeutics and biologics to be used in our lupus patients. I said earlier that life expectancy in lupus has improved in the last 50 years, but it's still far from ideal. So I hope you can make out these lines here. This is looking at life expectancy in years. The top line is the general population, females who have the longest longevity. Males fare a little bit less well in the general population with a lower life expectancy than females. The solid black line are all SLE patients, and you can see that they have a significantly lower life expectancy than males or females in the general population. But even worse than that, in the solid black broken line, or the thick black broken line, are lupus patients who have a history of lupus nephritis. They have a lower life expectancy than when you compare them to lupus in general. And then the very lowest line, which you can see is quite a bit younger and quite a bit lower than the other, are lupus patients who not alone have had lupus nephritis, but have residual renal damage. So I think this really clearly shows that our lupus patients have a lower life expectancy than the general population. Our lupus nephritis patients, even worse. And if they actually get established renal damage, they have a much lower life expectancy still. And if you look, that's particularly in the age group of patients in their teens, 20s, 30s, which is very worrying. And if you compare this to rheumatoid arthritis patients, I think that group are quite ahead of us in terms of biologics. They have a wider array of biologics available, and they have actually had a much better improvement in life expectancy. in the timescales that are shown in this graph. Yes, lupus has improved over the same time, but nowhere near as much as the rheumatoid patients have. So I would estimate that the rheumatoid focused rheumatologists and the rheumatoid patients probably have a 10-year advantage of being ahead of us or more progressed in terms of how well they use biologics and how many biologics are available for their patients. And then getting back to quality of life for lupus patients, this is what they worry about most of all. It's how lupus is impacting on their education, their work, their family life. This is quite an interesting survey from during the pandemic of a really large cohort of lupus patients across Europe. It was found that lupus patients who were diagnosed before the age of 25, at least half of them felt that lupus impacted on their education and studies. Almost 60% of patients felt that lupus negatively impacted on their career and working life, and almost 15% had just stopped working and were not in gainful employment. Half of lupus patients said they had a medium high or very high burden from their lupus, so that they couldn't perform normal activities of daily living and leisure activities that we take for granted. And over 70% of lupus patients said that they were less active than people of their same age who did not have lupus. And from that same survey, I think this is quite interesting. This was looking at the percentage of patients who were on immunosuppressive agents, which was about 40%. And what really struck me was the percentage that are on biologics was just around 10%, which I think is very low. And that brings me now into the talk of, well, what biologics are available therapeutically for our lupus patients if we have all these problems and unmet needs, all these terrible impacts on quality of life and patients' life experience. Why are only 10% of patients on biologics, and exactly what biologics are available and why aren't more available? So this looks like a wonderful slide. It looks like we have lots of options available, but unfortunately it's not as straightforward as that. So you'll see here in the blue, the B cell, which many of us are very interested in targeting in lupus. We know all about rituximab. It's been around for quite some time, so I'm actually not going to really focus or mention very much about rituximab in today's talk. I'm going to focus on some of the newer B cell targeting biologics, so a little bit about belimumab or Benlysta, obinutuzumab in particular I want to mention. Then moving on to the T cell in orange, we're looking here more at interesting cytokines. Of course, interferon is going to be mentioned. And we do now have anifrolumab, which is now FDA approved, big news headline for lupus. We also have voclosporin, which is a calcineurin inhibitor, also FDA approved for lupus. Moving down the slide to the lower corner, we have a couple of other cytokines like targeting with ustekinumab. Unfortunately, the trials of that have not worked out past phase 2, which is a common theme in lupus trials. And then the very exciting area of targeting plasma cells, CD19 with CAR T cells and CD38 with daratumumab, which I'll also mention. So a little bit first about belimumab. So belimumab targets B cell activating factor, which can be called BLyS, or other people call it BAF. In 2011, it was the first drug that was licensed for lupus since hydroxychloroquine. So that was quite a big moment. There have been 4 phase 3 trials of belimumab now that have achieved the composite score called the SRI-4. And they are the BLyS52, the BLyS76, and another one called BLyS-LN in lupus nephritis. Before we had BLyS-LN, there was a post hoc analysis of the BLyS52 and BLyS-76 that showed that there was likely to be a good response in renal patients, and that's why they went on to do the BLyS-LN study. So these studies were very exciting because I suppose one of the big excitements was that rituximab failed the LUNAR and EXPLORER trials of the nephritis and non-nephritis, which was a big disappointment. So at last we had a B-cell targeting therapy that had actually passed phase 3 trials. So that was exciting because of the drug itself, but it also taught us maybe a little bit about how we conduct lupus trials. So a more recent impactful study on belimumab was its impact on organ damage in the longer term in lupus. So this was a BLISS long-term extension study comparing organ damage progression in patients who had belimumab versus standard of care over 5 years. And they used a kind of a combination score called a propensity score that calculated several predictors of organ damage. And indeed, patients who were on belimumab in the longer term had lower organ damage. Again, I keep going back to the organ damage and damage accrual as being the key predictor of morbidity and mortality in lupus. So this is very encouraging from a B-cell therapy. There have also been a number of studies looking at sequential therapies targeting B cells. So these have all been combinations of rituximab and belimumab. There have been 4 sequential studies. They all were designed differently and they all had different results. So it's a little bit difficult to draw solid conclusions. There was a study called the BLISS-BELIEVE study that didn't reach its primary endpoint. There was another lupus nephritis study called CALIBRATE that didn't show a difference between the 2 treatment groups. There was another one called SYMBIOSE-1 and another one that I was involved in called Beat Lupus that actually showed very encouraging results. So the jury is still out, very mixed messages. As I said, they all had different protocols, but what they all had in common was that there was no worrying safety signal about giving combination rituximab and belimumab. I'm just going to give you one slide on the Beat Lupus study. So this was belimumab after B-cell depletion therapy. So this was, i.e. belimumab after rituximab. The patients, the 2 big outcomes were the time to first flare and the anti-double-stranded DNA titers. So the anti-double-stranded DNA titers at 1 year or week 52 were lower in the patients who received belimumab after rituximab. And similarly, there was a good signal with time to first flare. It was a delayed time to first flare in the patients who got belimumab after rituximab. I think this is an interesting area. It has probably fallen a little bit to the sidelines at the moment because people are concentrating on other advanced therapies, but maybe this will be revisited later. We'll see. So this is one of the more advanced therapies that has turned people's heads. This is obinutuzumab or OBI. So we know that not all lupus patients deplete well in terms of their B cells with rituximab. Obinutuzumab is a more modern second generation anti-CD20, so it has more enhanced B cell depletion. So the big idea, the concept is that if you get deeper tissue B cell depletion, you'll have higher clinical efficacy. So the first study, phase 2, that was caught everyone's attention was the phase 2 Nobility study. And there are now phase 3 studies, Regency and Allegory, going on in lupus nephritis and in non-renal lupus. In the UK, this is the Nobility study, the phase 2 study of OB in proliferative lupus nephritis. And indeed, it showed that there was a better complete renal response. And there was also quite a good reduction of steroid doses in the patients who got obinutuzumab in this study. As I said, the phase 3s are ongoing. In the UK, from the BILAG registry, which you'll be familiar with, we published 9 patients who received OB for secondary non-response to rituximab. You'll notice Obi-Wan Kenobi here, just for some light entertainment. So 6 months after obinutuzumab, these patients who hadn't responded to rituximab were actually doing very well with obinutuzumab. They had significant reductions in their SLE and BILAG scores. Their serology had improved. 8 of the 9 patients all were able to reduce their steroid dose significantly. Unfortunately, one of the patients was averse to having vaccines, was unvaccinated, and died from COVID-19. So I'm going to move on now to another new exciting therapeutic area in lupus. Well, it's not new. We've been talking about targeting interferon for a very long time. But now at last we have a drug that has gotten through all the phases of clinical trials, and it's anifrolumab. So this is a monoclonal antibody targeting type 1 interferon. It's FDA and EMEA approved. There were other interferon therapies along the line, like rontelizumab and they dropped out during development. So the program of studies has been called TULIP, the treatment of uncontrolled lupus via the interferon pathway. TULIP 1 failed to meet its primary endpoint using the score I mentioned earlier, the composite score SRI-4. They somehow managed to reanalyze using a secondary endpoint, which is the BICLA, a different composite score, and then it did meet its primary endpoint. And a different study called TULIP 2 did meet its primary endpoint using the SRI-4. And somehow the FDA were convinced, combining these results with phase 2 as well, that anifrolumab works for lupus. There is a nephritis study called TULIP-LN, which has also shown encouraging results, but it looked like they needed a more intense regime of anifrolumab in that particular study. So it's a little bit unclear yet. You'll all be aware of a potential safety signal of herpes zoster for when you target interferon. So anifrolumab, very exciting. It's the first approved therapy that is targeting type 1 interferon. The trials so far have been very supportive of its efficacy, so we're pleased about that. The questions we don't have the answers to, which can be applied to any of these new therapeutics, not just anifrolumab, is, well, which subset of lupus patients should get this therapy? And at what stage of their disease should they get this at the front door, the first day of diagnosis, so that you shut the lupus down straight away? Or do they get this when they have failed 2 or 3 or 4 other therapies? Do we combine it with other therapies? The cost and accessibility are always going to be an issue, and we need to clarify a bit more the role of anifrolumab in lupus nephritis. Moving on now to targeting different cytokines, JAK and TYK inhibitors. So you all know from using these drugs in a wide range of other rheumatology conditions that these drugs work very, very well. They target the JAK-STAT pathway, and we know that these cytokines are dysregulated in lupus, so it would seem like a good therapeutic option. Baricitinib was passed through a phase 2 trial, but unfortunately not phase 3, which again is a common theme in lupus trials. So Lilly actually pulled the development program for Olumiant or baricitinib. So unfortunately, that was the end of that. So for the moment, baricitinib isn't progressing, but there is a study ongoing at the moment of deucravacitinib. It's called the POETIC study. This drug is a TYK2 inhibitor, so also targeting the JAK-STAT pathway. This drug has done well in phase 2 in lupus, and it's doing really well in psoriatic and psoriatic arthritis as well. So we actually are recruiting to this study at our centre. So this is hopefully going to be successful, and time will tell. Just a small break for light entertainment to show that JAK inhibitors still do work. This is actually my dog. His name is Scooby. And a little while back, he had quite a nasty rash and an itch, and his vet diagnosed atopic dermatitis. And my husband brought him to the vet, and he came home with a tablet that made everything better within days. And I assumed it was an antihistamine until a little while later I had a closer look at the tablets, and it was actually a JAK inhibitor. So I have first-hand evidence that even though we don't have great signals for lupus yet, we do know that it works for dogs. So briefly, calcineurin inhibitors. So the reason I have this doctor here looking a bit confused is I think as rheumatologists, we were always a little bit nervous about the older calcineurin inhibitors. We have used them in myositis, and interstitial lung disease, and the lung doctors and dermatologists like to use them. But I think we were a little bit hesitant. How they work is they impair T-cell activation by interleukin-2. But they also have renal positive aspects like podocyte stabilization and reducing proteinuria. So the new calcineurin inhibitor is called voclosporin. So now this doctor is looking much happier about this. The big study for this was called the Aurora lupus nephritis trial with Brad Rovin in the States, who runs a lot of the lupus nephritis trials. So this was background Cellcept with an inbuilt steroid taper. The proteinuria drop was really impressive and rapid, and the ability to reduce the steroid was also really impressive. So this is very exciting. So this is promising for voclosporin. As compared to the older calcineurin inhibitors, it's a much cleaner drug. You don't need levels, as it has predictable pharmacokinetics. It's actually a more potent calcineurin inhibitor, and there are less nasty off-target effects. So just a news flash here, you'll have noticed that quite a lot of drugs there are becoming FDA approved for lupus, where we hadn't got anything approved for 50, 60 years. And now we have Benlysta in 2011, anifrolumab and voclosporin in 2021. So it is quite exciting. But a little bit of a dampener on the enthusiasm is the amount of drugs that are FDA. I have nothing against rheumatoid arthritis. I'm just a bit jealous and have a green-eyed envy here, as shown by the Hulk. So just look at all the drugs that are approved for rheumatoid arthritis and look again what we have for lupus. And this is why I'm saying we're really lagging behind, and I hope this changes. Now at last on to CAR T cells. So CAR are chimeric antigen receptor modified T cells. They are genetically engineered. This is a cartoon from oncology and hematology, who are much more advanced than us. So they recognize CD19 and other B cell surface antigens. And CD19 plasma cells in the bone marrow are not really touched or targeted by our anti-CD20 therapies like rituximab. CAR T cells are being used, as I said, by these other specialties in hem-onc and have caused a paradigm shift in how they manage certain lymphomas and leukemias. So why would we target them in autoimmune disease? I think it's self-evident. We have had improvements in biologics, but we have a ways to go. And I think even though we have improvements, these drugs are still suppressing the disease, but not really curing autoimmunity. Our diseases still have flares despite B-cell suppression rather. And we see that new drugs like obinutuzumab that can have more in-depth or deeper B-cell depletion are doing better. So can we go one step further and actually target them even more by CAR T-cell therapy? So what is so special about CAR T cells? So they have certain properties that might explain their superiority over our monoclonal antibodies against CD20. So if you remember back to medical school, long time ago, CD19 in B cell development is expressed more broadly than CD20, particularly on plasmablasts and the majority of plasma cells. So rituximab will deplete B cells with some secondary loss of plasmablasts, but it doesn't touch them that much. Whereas CD19 CAR T cells are directly cytotoxic to plasmablasts and many plasma cells. So they're much more potently depleting than our current monoclonal antibodies. They have better tissue penetrability and they're just more lethal to these cells. So the very exciting work from George Schett's group out of Germany. We've had this New England Journal paper this year. They now have 15 patients. There have been a number of smaller papers describing the group as the group was growing. They're not all lupus. There are 8 lupus in this paper, 3 inflammatory myositis and 4 scleroderma. They've all had, in this report, 1 infusion of CD19 CAR T cells after preconditioning, I'll show you what that is, with fludarabine and cyclophosphamide. And they've followed them up for 2 years, and this is what they have so far. So they've looked at safety, they've looked at efficacy, and they're particularly looking at unusual things that we don't see with our drugs like cytokine release syndrome, and I'll tell you about that. So this is a slide from the group when it was smaller than 15 patients. And I just want you to look at the bit that says timeline, which is how they're conditioned. So day -13, leukapheresis happens. Then the preconditioning, which is the fludarabine and cyclophosphamide. Then at day 0, the CAR T cell infusion is given to the patient, and then they're monitored. So this is from the New England paper. So as I said, it's a mixture, small numbers, a mixture. So 8 SLE and then the myositis and scleroderma. So what I wanted to draw your attention to is the little bit that's called B, where it shows the long-term outcomes. So you can see the SLEDAI has just dropped to baseline from having been quite high in these patients. You can also see the anti-double-stranded DNA from being quite high titers has just evaporated. And you can see the complement levels, C3, were really low, and how they've come well above the normal level. So all very impressive. You can see some nice changes with proteinuria as well. You're not going to be able to read all of this, so I would suggest that you have a look at the paper, but you'll see that this indeed was a very complicated group of patients. They'd had a huge amount of immunosuppression before this, but still had very active disease. So kind of the worst of the worst patients. So I'd advise you just to have a look at the paper to get a feel for, you know, how sick these patients were. The next slide is showing the short-term safety of CAR-T in lupus, in these autoimmune diseases. I draw your attention particularly to what they call CRS. So CRS is cytokine release syndrome. They see quite a bit of this in the heme-onc patients who receive CAR-T cell therapy, but actually the autoimmune patients, it didn't seem to be a big issue, and those who got it was a very low grade, it was mild. So from the small patient cohort so far, this seems to be less of an issue than in the heme-onc world. In terms of infections, not a really huge signal that was worrying, but they did seem to pick up quite a bit of COVID. Hard to know, is that just the state of the world today or something specific to the therapy? But I think we need bigger numbers to understand what any of this means. So as I said, there's much longer term data from heme-oncology. They see a lot more of this cytokine release syndrome. They also see some neurotoxic effects that are reversible. I'm not sure we saw a lot of that in the rheumatology patients. And then longer term, those guys have been seeing things like B-cell aplasia, hypogammaglobulinemia, and some infections. And that hasn't been seen in the rheumatology small cohort so far. So this last few summarizing slides. So far, so good. The observations from George Shett's group, and I think we'll hear about a case from one of our colleagues here. It's been in uncontrolled studies in small heterogeneous patients with limited follow-up. So we have all those caveats, but it's still exciting, still remarkable findings. The toxicity in our patients seems to be manageable and mild. You might say, well, why don't you do autologous stem cell transplantation? That would be similarly efficacious, but a lot more toxic. So what do I think? And maybe this is more for the question and answer session of the future of CAR T cell therapy in lupus. So I have a picture here of someone with their crystal ball, which is what we might need to answer this question. So does this therapy cure autoimmunity as opposed to just immunosuppressing? What is the future for CAR T cell therapy? And this is going to be dictated by what we see in efficacy in future studies, and what we see in safety, and a big thing, the cost and acceptability. But if the data continues to look like it does, I think the benefit risk ratio will be acceptable both to us as physicians and to our patients, certainly at least for the very severe refractory patients that we see. The issues is that this is very individualized. It's difficult to scale up to big population groups, and it's expensive, and it needs a lot of expertise in your medical center. But at the same time, chronic autoimmune disease, like a chronic lupus nephritis patient needing dialysis or transplant, well, that's very complicated and expensive as well. So, and it's likely that CAR T cell, as it becomes more advanced, will actually become less expensive, hopefully, and there will be more expertise over time. So is CAR T cell tolerogenic? Does it cure autoimmune disease? We don't know. It's promising. The question will be raised, well, can you give it to less severe lupus patients and earlier in the course of disease? But I think we're many years away from that yet. So the future, other considerations, we need to keep an eye on our heme and oncology colleagues and their literature. They're doing different things like giving different B-cell depletion before CAR T cell. They're doing different conditioning regimens, not just always fludarabine or cyclophosphamide. And the technology is improving as well. There have been some recent reports of secondary cancers in the oncology patients, so we need to keep an eye on that. And we need our own actual proper phase 2 trials, and these are starting. Just last thing to mention, daratumumab, which targets CD38. This is, again, only been given in a couple of lupus patients. It targets plasma cells. Just these two patients here, I'll show you. You can see how complicated they are and how many different drugs they've been given. Daratumumab is actually used for multiple myeloma. In my center, we recently had a myeloma patient who also had lupus, which was pretty severe lupus. She was given daratumumab for her myeloma and her lupus has improved. So we should write that up as a case report. So this study, just N equals 2, but these two complicated patients did very well with daratumumab. I'd advise you to, again, look at the New England paper, but you'll see that clinically and serologically, a huge drop in activity, a huge drop in antibodies, so also a potentially exciting new therapy. So therapeutics in lupus in 2024, I'm back to Scooby here. We still have unmet needs. We all know this. We don't know what the appropriate subset of lupus patients for any of these particular new exciting therapies are. And we don't know, should we use them early in disease or later when they have failed a number of our current treatments? Should we combine these therapies? Are we going to be able to afford and make these accessible for our patients? So a lot of worries and a lot of questions. So to finish, therapeutics for SLE, CAR T-cell therapy and beyond in 2024. The reason we talk about these topics is we want better remission for our patients. We want the option of using new and potentially multiple agents in combination earlier in our patient disease course. We want to minimize corticosteroids. We want to have better predictors of disease outcomes in trials and better biomarkers if that's possible. And I'll finish with a happy memory of meeting a lot of you guys back in Chennai in March when I traveled to India to a fantastic rheumatology masterclasses and just some very nice photos that were sent to me afterwards, and thank you for that. So I think I'll pass back to the organisers now for the questions and answers and discussion.
Yeah, thank you, Dr. Natasha, for such an illustrative and very nice demonstration of what we are dealing in 2024 with lupus. So this is a CAR T cell is definitely one of the most exciting therapeutics in the armamentarium of the lupus. I have one question regarding like what will be the theoretical chances of having relapse after CAR T cell therapy?
So I think at the moment they don't know. It's such a short follow-up in this small group of patients that the ones they've given it so far, they seem to have done extremely well. So I think we just don't know. I think we don't have a large enough group and we don't have long enough follow-up. So I think this is something that only time will tell, and larger groups of patients.
Yes, and another thing that you have rightly pointed out, though, this infection is one of the major issues with the CAR T cell, though not significant number of infection has been recorded as of now for the rheumatological patients. But for Indian context, that remains one of the major challenges for us. And recently at KINS, Hyderabad, Sarat sir has done one of the CAR T cell therapy in one of the lupus patient. So if you like to share your experience and if you have any question related to that? Sarat sir?
Dr. Agya, you're asking me?
Yes, sir.
Yeah,
so,
no, this is not a lupus, it's actually scleroderma.
Scleroderma, okay.
Yeah, just 6 weeks old, where, because scleroderma, we're expecting that it may take longer time to see the clinical results.
Okay.
And I suppose certainly at the moment, because it's really the worst of the worst patients getting this in our patient cohort, getting CAR T cell therapy. So they've probably had a huge amount of immunosuppression and an awful lot of steroids already. So you already have this baseline higher risk of infection to start with because they've been so difficult to manage. And then you give them the CAR T cell. So it might be hard to tease out the different contributors.
Yeah, like the Lunar and Explorer, the Redux was a failure. So like possibly in future with the more use of CAR T cell, possibly the middle group of the patients will be the best. We don't know, only time can tell us.
That's a very good point. That's a good point. Yeah.
because in the extreme stage, the patients are already there on a cumulative dose of steroid also very high. So chances of getting infections is also very high in that group of patients. So eventually they'll end up in more infection and leading to catastrophe and death of the patients. So then possibly we have to choose relatively earlier than that they may be a better candidate for this kind of therapy. Any question in the chat? Vinod sir, you have any comments?
Yeah, I wanted to actually ask Sharad because, I mean, in terms of chronicity and the disease burden, I mean, of course, both the diseases, lupus and scleroderma, are different, but same in some aspects. So before, like for example, when the CAR-T cell therapy is contemplated, they would have had a significant amount of immunosuppression anyway. So in your patient, Sharad, sort of in what were the things which led you to choose CAR-T therapy?
This patient earlier, he tried different DMARDs. He was on methotrexate, mycophenolate, and endoxan, cyclophosphamide. But despite of all this, the disease has progressed. And interestingly, actually, this guy, he's basically a software engineer. He himself studied more than us. And he came to us. He asked for the CAR-T himself. So initially, I tried to say that, we can try some more way of, giving, like in my practice, I give a aggressive therapy in the form of combination of methotrexate, mycophenolate, plus rituximab. I must say, I've seen very good results. I'll share you my experience, in the clinical trials. I have 2 ongoing clinical trials for scleroderma, but none of my patients actually meeting the Rodnan score to include them in the study because of the aggressive therapy, I feel, because as soon as we know that this is behaving badly, we start this combination of methotrexate, mycophenolate, plus rituximab. Of course, we keep a close watch on the infections. Fortunately, none of my patients had any major issues. And I forgot to mention, Dr. Arke, you asked about the experience. In this particular patient, there were no infections. We achieved B-cell aplasia quickly, and he suffered mild cytokine release syndrome, and we dealt with giving trastuzumab, and so far he's good. He's doing good. Some of his the pepper part, the pepper salt appearance on the skin started disappearing. He gained 5 kgs weight.
Okay. So, sir,
You got some questions here.
Yeah. So, like as you are discussing recently, you have the experience, Indian context. So many of us are excited to know the outline of the physical and logistic steps, and like what are the cost of the therapy. So that we can guide our patients. At least we can discuss the therapeutic options for our patients also.
Yeah, here
this is for Dr. Jordan, actually. This is for Dr.
Yeah. So I happen to use this therapy myself. The hematologists in our hospital have, and I would be nervous to do this in a hospital where your colleagues in hematology or oncology haven't used it. I think it's nice to have them around who've had the experience of it. So that would be my first thing. Certainly at the moment, I don't think our hospital would fund a lupus patient to get this therapy. So I don't think it's an option available to me. If I was to approach our managers to get this treatment, I think it would have to be a really, really severe lupus patient who has failed all other therapies, who, as colleagues have mentioned, maybe that's actually not the ideal candidate. Should be someone maybe in the middle. So counselling patients and that now. I'm not in a position to do that because I just don't have this available to me. Most hospitals won't, but certainly I think from a practical point of view, I wouldn't be comfortable doing it in a hospital if I didn't have, as I say, those heme-onc colleagues who are familiar with this and familiar with the cytokine release and things like that, so they could actually advise you. I think that would be a practical common sense step to have the backup of those and counsel of those colleagues.
Right. So, like Dr. Natasha, is there any clinical and laboratory hints in lupus patients to consider CAR T cell therapy?
Is there any clinical or
serological hints
of ones who should get it? Yeah. Well, I suppose your very active patient that you saw in the small group of 8 lupus patients, that they had very high double-stranded DNA, they had very low complement, but that will just be representative of any very active lupus patient. I suppose if you had, in particular, a rituximab patient who didn't deplete their B cells very well, and you for some reason didn't have access to obinutuzumab, but you did have access to CAR T cell. This is a very hypothetical scenario, but it might be, that might be it, so yeah.
Right. Like Sarath said, we also want to know, because you are the first one from India who has done this, what are the physical and logistic steps in Indian context?
First of all, honestly, speaking, I wasn't very, happy doing this. The reason is we don't have the consequences. We don't have any Indian experience. You don't know what are the kind of adverse reactions to this, and our ethics committee didn't approve it initially. So, because the patient himself volunteered to take this therapy, so we asked the ethics committee. They said then go ahead, and then we took permission from the DCIA, and we got a special license to use this product for personal use. And we took the help of Oxy-T-Cell from Malaysia. They helped us in procuring this CAR-T from them. And it did cost around 55 lakhs altogether, including the hospital costs. And here we used a GL CAR-T, BCMA plus CD19.
Okay. There are a few more questions not directly related to the CAR-T, but Dr. Natasha, what is your domain of use of anifrolumab? It is for refractory skin or any other indication? It's a question from Igna.
Yeah, so I can give you what the EULAR guidelines say, and then my personal experience of it. So in the EULAR guidelines, they introduce anifrolumab after patients have had the kind of standard immunosuppression like Cellcept, Imuran. So they bring it in at that level. Then my own personal experience, we've given our first patient anifrolumab just recently. This particular patient did have a past history of lupus nephritis, but not current. And she had the worst skin disease I think I've ever seen. It was absolutely awful. Her skin, her face, her trunk, in her ears, in her mouth, she could barely eat with palate involvement. She had rituximab, she'd had obinutuzumab, she'd had ustekinumab. We gave her a JAK inhibitor. She had all the other standard stuff over the years, absolutely everything. Nothing touched her skin. She had her first infusion of anifrolumab, barely recognizable. The skin lupus just melted away. Unbelievable. I couldn't believe how much she improved. I know from Ed Vital, who was also over there in March, he's a big believer in anifrolumab as well, certainly for skin. So yeah, that was my experience. So skin is fantastic. Skin and joints, good. And as I said, there's the TULIP LN study that's showing good signs for lupus nephritis as well. So it's a good drug. Again, boils down to the cost and availability, which is, I think, the challenge for everyone. I would use it a lot more in our patients if our hospital finance would let me. I would give it to a lot more, not just this one severe patient. I would easily have several dozen patients I would like to give it, but they won't let us.
Okay. And what is your opinion regarding the use of CAR-T in monogenic lupus?
Oh, that's a good question. So I suppose if monogenic lupus is so rare and it is one gene, so a lot of the genes for monogenic lupus are interferonopathies. So those patients might be best placed to get like anifrolumab, for example. It would depend on, is it just a suspicion of monogenic lupus because it's a young child or a really strong family history of parents, siblings, or have they actually identified the gene? So I think if they've identified the gene and it's an interferon one, you might be tempted to go. So in our children's hospital recently, there's a kid with a monogenic lupus and it's an interferonopathy. So they're going with targeting interferon, not CAR T cell. It's a really, really interesting question.
Rightly, like the pathogenesis being much different from like interferonopathies and the lupus. So there's another question from Dr. Devender. Lupus patient having renal amyloidosis secondary to uncontrolled disease activity. Can CAR T cell therapy help in such cases?
I mean, we don't know. You would worry if the disease activity, renal amyloid from uncontrolled disease activity. So you would, I suppose, want to confirm on the biopsy, which I presume the case has because they know it's amyloid, but you'd want to know what class of nephritis it is. If it was class 6 and it's a sclerotic, burnt out lupus nephritis, I'm not sure lupus nephritis is the target anymore. If it's just the amyloid part. So that's a difficult one. Is it still lupus is the problem? Because you want to you would target lupus with CAR T cell, but I don't know if amyloid would respond to CAR T cell. So I would establish, is it still active lupus nephritis or not? Yeah, if you follow me.
Okay.
Yeah, can I answer, Dr. Agya?
Yes, sir. Sure.
Yeah, I feel, it is the background lupus activity causing amyloid. But in my practice, I haven't seen lupus with, amyloid kidneys. But I do have around 3 patients with chronic rheumatoid developed amyloid. When I aggressively treated RA, the amyloid disappeared. But I'm yet to see a similar experience, said to have a similar experience in lupus. As long as you treat aggressively, tightly control the disease, then you may not see amyloid at all.
So there are some possibility that will reverse. So, Dr. Natasha, do you have any, what is your opinion regarding the reversibility of the pulmonary hypertension and scleroderma with the CAR T cell therapy?
Yeah. I don't think anyone knows. I mean, all we have is our colleague here with the one case of scleroderma. And then in that New England paper where they had, 3 or 4 cases of scleroderma. And I think in the paper they focused on reversal of the active inflammatory aspects of the scleroderma, like the skin and the pulmonary fibrosis. But I suppose a lot of the pulmonary hypertension is a kind of a degree of it is the knock-on effect, the kind of hemodynamic effect that isn't inflammatory per se, but no one knows.
No, exactly.
Nobody knows.
So, we have another interesting question from Siddharth. What is your thoughts on CAR Treg, CAR NK, and non-CD19 CARs for autoimmune disease?
Yeah. So CAR Treg, I don't think we want to kill Tregs because they do lots of good. So I don't think we necessarily want to obliterate them entirely. And then the others, so NK cells, again, I suppose we're thinking that so much of lupus is driven by B cells that we would rather target them than NK cells. So I'm not sure targeting NK cells is going to make a huge amount of difference in lupus. And then non-CD19. So I think they're meaning other markers that are on B cells. Maybe there's some sense in that. But again, no one knows, and I don't know what other CAR T cells hem-onc have used that aren't CD19. I don't know what other targets they are likely to have done other things. We've done very little, so no one knows.
And I just, yeah. So Dr. Sharath, what was the cost for your patient having this therapy, roughly?
55, I think.
55. So that is how much?
Altogether 55 lakhs.
So that's how much in
So
US
probably
dollars,
in
so
pounds,
that we can have a
probably in
50,
pounds, maybe
50, so
55,000 pounds.
55,000 pounds, is it? Okay. So, Natasha, in your hospital where the oncologists are using, I mean, is that roughly, the cost implications for sort of the healthcare system?
Yeah. So I think the way they're looking at it in the leukemias and the lymphomas is that it would be curative, and then they don't need other expensive interventions or prolonged hospital admissions. And when they weigh up the cost, the CAR T cell is worth it. I think in our patients, if we approached one of the managers with a moderately active lupus patient, they're going to say, well, the cost of treating them with your current treatments is no way anyway equal to what CAR T cell is. So they're going to say no. So I think it's the curative aspect of the oncology ones, and that they see the cost effectiveness of that. But it'll be hard to convince them for a lot of our patients that the investment is worth it. Why can't we carry on with the cheaper drugs we have? Because I think they don't, I suppose, you look at a leukemia or lymphoma patient, you think of their longevity is in months, whereas a lupus patient, yes, they have a lower longevity in the general population, but they're not in immediate danger. And I think the managers aren't going to look at it in the longer term. But I think probably agree with me with that. Yeah.
Okay. We have two, three more questions. Like, any role in refractory DH and lupus with this CAR T?
So diffuse alveolar hemorrhage, we don't know. I'm not sure if that was a feature in one of the 8 patients in the New England paper. So we don't know.
And another is like managing cytokine release syndrome in CAR T cell treatment. Is it something different from like hemat-onc treatment versus vis-a-vis the autoimmune disease patients? Is there any difference in treating?
So I think the difference is the frequency and the severity. So again, the small group they had in that paper, they didn't seem to see it being as frequent or as severe as the hem-onc patients. So they didn't think it was a big concern. And I think our colleague has said that the patient they had a mild CRS, which seems to be representative of the experience of the German group. And I didn't. You said how you treated it, but I didn't catch what you said.
Yeah, usually, as per the literature in autoimmune conditions, the cytokine release syndrome is mild and easy to manage, and they do get better with using tocilizumab, but at a very high dose.
Mm-hmm. So,
and the other thing, regarding somebody asked about the DH and all, we can't use CAR T cell in acute setup. For example, your patient is admitted with DAH in for CAR T cell. The patient should be relatively stable at that point of time. The patient have had, multiple flares in the past, that drug resistant with different combinations. So at the time of CAR T cell therapy, patients should be relatively stable, because again, at that point of time, you have to stop the DMARDs temporarily for a few weeks. Then you have to give, fludarabine and endoxan to do the leukapheresis, and you have to send the leukapheresis blood to the center where they process the CAR T cell. It'll take at least 2 to 4 weeks to get it back to your center. So you need at least 4 to 6 weeks time for the patients to be stable to receive CAR T. So acute flares, bad flares in ICU, not a good candidate, not suitable at all.
That's an excellent
Right.
point.
Yeah. So, any other final words from your part, Sarath sir, especially in Indian context?
Yeah, if I think what I would suggest to IRA, if you have a group of rheumatologists who are interested to do it, along with the hem-onc people, maybe you can do a better job quite early, because we all know Tata hospitals in Mumbai. They have been manufacturing the CAR T. They're providing for the cost of 30 lakhs per patient. So if the hospital is friendly, if they don't charge much, maybe you can do it for around 35-40 lakhs for Indian patients. You don't need an intensive care or any clean room. You can do it in ordinary, regular, single room. It's not that expensive, actually. If we all can come together, we can do wonders.
Absolutely. Absolutely.
Sure. Absolutely. So, over to Vinod sir. It was a nice and excellent discussion, and I found no more question. And Sarath sir has a very important points, like we need to explore this area, because lupus sometimes we found very difficult to manage despite trying all the options we have. So it's definitely could be one of the major path-breaking therapies for the lupus in future, and especially for the young lupus. This could be a very important step ahead for treatment management of the lupus. So with this, over to Vinod sir for the final words.
Thank you. I would like to start by thanking Dr. Arghya Chattopadhyay, who has wonderfully moderated this session, Dr. Sharath Chandramouli, who has shared his experience of this therapy in a patient with scleroderma, and some really important take-home points when to avoid. And it actually also showing that it is possible to do this in India when we consider that in the other parts of the world also, the therapy in autoimmune diseases with this therapy is just only starting. So I don't think, okay. I think that FDA approval would probably help ease the pathways of care for our individual patients here, especially in terms of ethics. I thank the IRA eConnect team, Dr. Mohit Goyal, Dr. Damodaram, and our president, Dr. Chandrasekhara, for their support in setting this up, and our ICS global team, our tech partners for the IRA eConnect, and Dr. Natasha Jordan for her wonderful talk. And I think the three-way split of her talk was really wonderful, telling us where we are and what are the therapies and horizons, and then discussing in great detail about the very focus of the talk today, the CAR T-cell therapy in patients with lupus. And last but not the least, our esteemed members of the Indian Rheumatology Association for joining us in this academic session. So once again, I would like to thank all of you and look forward to see many of you in ARACON 2024 at Bangalore next month. Thank you and have a great evening. Thank you.
Thank you. Thank you.
Thank you. Bye-bye.